is not available today. Okay, so we will see some other details now. Okay, about complete. Generally, with all this transformation now in our lab with T7 and all these panels, with complete, we decided to promote these panels with these genes for lung cancer, colon cancer, and breast cancer. So let's see what other things we have now. So the agenda here is to discuss about single genes very shortly, about prime ready score MGS, prime new reports that, okay, I'm not sure that we are ready. Okay, very soon we will ready, and we will discuss about the use of whole exome RNA and how to use whole exome RNA and where to use whole exome RNA. So let's start with single genes. Okay, do you have single genes? Do you have physicians in Turkey to ask about single genes? I don't think so.
Sometimes.
Yes, doctors ask sometimes, but then when we offer like 3 single genes together, it costs much.
Okay.
So it's off the table.
Okay.
Yes,
Okay.
when we are discussing about single genes, we're not discussing about KRAS and RAS, BRAF, EGFR, the most famous genes. Okay, we're discussing about the most rare single genes. For example, PIK3CA in breast cancer, for example, IDH1 and GMT. MGMT it's not being included in this panel, but what else? What else? And DRK, for example, sometimes.
Yes,
I think these are the most famous genes that somebody
Yes,
will ask.
Okay,
So,
all this transformation that we are doing now in GeneCore is in order to be ready to have all the tests that we provide to our physicians CAVD. Okay. So for this reason, we have, okay, some differences between liquid and tissue because, okay, it is not easy for a small panel to be CIVD. Okay, so all these things now, all these panels are CIVD. And of course, this is very good for the physician, for us, for the patients, because, okay, we are understanding that we provide a reliable result. So about
Spiro,
yes.
can I please say something about CAVD? Just, I know there is a presentation tomorrow from Dimitra about, she's going to present to us a few slides about CAVD, but just a few words. This is going to be mandatory in whole Europe for all the labs, for everything that is connected with, not with molecular biology labs and all these things, with any kind of labs, the reagents, the machines, everything should be CIVD, like the laptops, okay, all the things that they are, as you can see, there's a CE mark here, okay, everything has this sign. Maybe this won't, let's say, influence your job a lot, but it is like similar, like FDA approved. Okay, this is the approach where we should put that thing on the table with our doctors. Okay, this is very important. This increase our reputation. This increase the validity of our panels. This increase the quality of the exams that we provide because everything it's CIVD. It's not a common panel or a platform that we are using just in order to provide some exams, some results to the patient. It's something that it is accredited, it's certified, and it's CIVD. So this is why we are staying a lot to this thing because it's really very important. Maybe not so important in a country which is not a member of the European Union, but at the end of the day, it's going to influence our results, and it's going to influence the CIVD, our quality of exams. So this is something that we need to, discuss with our doctors. Okay, sorry, Spiro, sorry.
Okay. Thank you for the clarification. So, in order for this, for cyclic genes, now we will use these two different platforms, okay, which is CIVD. We are using these Attila platforms. There is no reason to care with which methodology, with a hotspot panel, with Attila lung cancer panel, we provide the test. The lab will decide if you have, for example, an NTRK fusion that a physician wants to prescribe for a patient with a sarcoma, for example. Okay, you will send NTRK fusion or PIK3CA for breast cancer, and the lab will decide with which platform will run the result. The importance here is that all these, the testing is CIVD, so we don't have any problem. The only genes that which are missing are KEAP1 as a prognostic biomarker in lung cancer, POLE, so we don't have the possibility to run POLE separately, and ESR1, because for ESR1, okay, we have the complete DX breast to do the panel, which is CIVD, and we have, of course, doublet digital PCR that we run based on the contract that we have in Greece with Menarini. So MSI
Turkey is the same approach, is the same technique that we are using for liquid.
Yes, sir.
For liquid ESR1. Okay.
Okay. MSI, now for your information, but okay, we don't care except Prime, because in Prime we provide MSI by NGS. For the smaller panel, like Complete DX lung in tissue, like Complete DX colon in tissue, that we provide MSI, or if you have a MSI test separately, we are doing now MSI by PCR, by real-time PCR. There is no need for collection of blood, okay, just in tissue. So we are doing MSI by PCR, except Prime, okay. For all the other exams in tissue, either cyclic gene testing, either complete in tissue, we provide MSI by real-time PCR, which is a CIVD testing. Okay.
I couldn't understand why the KEAP1 is missing genes.
Because it's not part of this platform.
But are we going to give the KEAP1 result?
Just a moment. Okay. I don't want to be confused here. Okay, Ravi, you are right. Don't look at this platform. Don't look at these panels. Okay, when we have a cyclic gene testing, we have to run one of these two platforms, but we will provide IDH1 and track whatever is the physician is asking. Okay. So we have this methodology, which is CIVD methodology, to run whatever cyclic gene test a physician will ask, except KEAP1, POLE, and ESR1.
Okay, I see.
Okay, good.
But if somebody, Spiro, somebody wants KEAP1 or POLE or ESR1 in tissue, okay, not in liquid, we have the ability, another option as a single gene with real-time PCR. But the problem is that we need to find a solution in 6, 7, 8 months, 1 year, when the thing will be transformed to everything should be CIVD. We need to find a solution also for a CIVD solution for POLE, for KEAP1, and for ESR1 if we want to be, to follow this new regulation that is going to exist in European Union. But now, in the time that we are discussing, there is no CIVD test for CAP1, poly, and ESR1.
Okay, LSS strand is connected with ESR1 mutation. If we talk here in the stem line, Menarini, Turkey, and if they ask us, do you have CRVD certificate for ESR1? What should we say?
Yes, we do. We do have, Spiro, can I answer?
Yes,
Okay.
of course, for digital.
We do have a CIVD test because Menarini cares about the liquid performance of the exam,
Mhm.
not the tissue
Yes.
perform. Okay, so yes, we have a digital PCR that we are using in our lab, which is CIVD,
Okay.
and this is the solution that we provide.
Okay.
Okay.
Also,
So, guy-
Spiro, sorry,
Yes.
this
Yes,
was
yes.
a very good comment from Ravi. The CIVD test, if we want to make collaborations with pharmaceutical companies, there is no other option on their minds, on their bosses, which exist in Europe, where they should receive money in order to finance these programs, these projects, everything. They are looking because it's going to be part of, let's say, of a project that they are going to create. They are looking only for CIVD tests. Believe me. Okay, it was a discussion with Johnson and Johnson. Johnson and Johnson, correct me if I'm wrong, but it's a US based company.
Yes, yes.
Okay, so the first thing they asked about PDL1, it was 2, 3, 1 month ago, something like that. Okay, when they approached me, they asked about CIVD test. Okay, this was the first thing they asked. That there is no need for us to move to the discussion if we don't have a CIVD solution.
Okay.
Okay.
Okay, guys, generally that Dimitris told you. Firstly, about PACES. Okay, now we have a cheaper methodology to run all these tests in order to have an affordable price, not to have, for example, for EGFR mutation to give 500 euros, okay, in order to have an affordable price for patients. And secondly, of course, if we want any collaboration with any pharmaceutical companies, because they are looking for one gene, for example, in this case, we have this CIVD platform to run the test and to have a contract with pharmaceutical companies. Okay, this is the reason. Okay, generally, we don't care about single gene testing because our goal is to provide panels, not because we want to increase our revenues, whatever, because panels are important for patients. Okay, we understand the role of complete or panel for lung cancer, colon cancer, breast cancer, for any cancer type. Of course, prime, complete, whatever is the best solution for patients. Okay, so let's go to prime. Okay, about ReadyScore. Okay, ReadyScore, HRD score, because okay, we name HRD score in GeneCore as ReadyScore. We know the role in ovarian cancer. The role in ovarian cancer that if we have a genomic instability score high, in this case, olaparib plus bevacizumab is indicated for maintenance treatment for patients with ovarian cancer after a response to a platinum-based chemotherapy in the initial treatment. So in this case, except olaparib, of course, also niraparib could be used. So in this case, of course, we provide ReadyScore in ovarian cancer. Okay, you know about ReadyScore. I don't want to repeat information about you, that HRD is very important. The only cancer type where HRD is indicated, is approved, is in ovarian cancer. We are looking for consequences of homologous recombination deficiency, looking for the effect instead of looking for the causes of homologous recombination deficiency, looking for gene mutations. So in these things, genomic instability score we provide by a platform, a test with bioinformatics, and to provide a result. And of course, the cutoff of HRD now is 42. Is 42 by bibliography, by Myriad, and by our test. So ReadyScore that we have now, we provide now in all these patients, is We have two publications with this ready score and with a high concordance with the gold standard My Choice by Myriad. And now let's go to see what we will do. What we will do next week from Monday. Okay. HRD analysis will be done in our lab by NGS. So by NGS now, we are waiting the publication of this validation study that we had 89 patients with ovarian cancer, and we did this validation versus My Choice from Myriad. So we are running now PRIME, okay, and based on an algorithm, we provide HRD score as other tests that you have in Turkey, like Caris, like Tempus. They provide HRD based on NGS technology. So we have now the same technology now, almost the same technology. So in this validation study that we are waiting the publication very soon, the publication was accepted, but we are waiting just to publish this trial, this validation study. We have an overall % agreement with My Choice by Myriad about HRD score 92.68%. So we have a very high agreement with My Choice. So based on this publication and this validation study that we believe, and we are waiting the publication, we believe that this testing is reliable to provide HRD score, a ready score, for all patients with ovarian cancer, or we will see in which cancer types. So now we decided in GeneCorp to provide HRD in combination with PRIME. So if a physician will ask you a PRIME test for a patient with ovarian cancer, with breast cancer, with pancreatic cancer, with prostate cancer, we will provide the PRIME result plus ready score, free of charge, with no extra charge for the patient. So in the price of PRIME, for these 4 cancer types, HRD will be provided to the physician. For other solid tumors, for example, you have a patient with gastric cancer, and the physician will be interested in having HRD score. In this case, the physician will have to ask you to add HRD in the analysis of PRIME. If this would be done in the initial testing, there will not be any extra charge for the patient. If the physician, after asking for PRIME and 1 month ago, will tell you, for example, okay, Zeynep, I have this patient with whatever, with cholangiocarcinoma, can you give me also the HRD result? In this case, we'll have an additional cost because we have to analyze HRD based on our algorithm. Why we are doing this strategy? Because we don't want to give HRD in any solid tumor, because in this case, maybe would be a confusion from the physicians and from the patients. So we believe now in GeneCorp, okay, HRD is mandatory. No, it's mandatory, it's very important in ovarian cancer, but is also important in breast cancer, in pancreatic cancer, and in prostate cancer. For these cancer types, HRD would be given with no other information. PRIME in breast cancer, we will provide PRIME plus HRD. For the other cancer types, there is a need the physician to ask in the initial testing in order for the patient to not have an extra charge. It's okay?
Okay, Spiros,
Is this
time
good
out.
information
Time,
for
time,
you?
time,
Yes.
time. Is it okay? Is it understood? Is it everything clear?
Herkes anladı mı? En başta istenirse yani doktor onu da istiyorum derse içinde dahil. Yes. Ama bir prime yapıldı bir ay sonra hani bir de ready score dediğinde o zaman o ayrı fiyat.
Birlikte tamam.
Hı hı. Yes, it's understood.
Belirtmesek peki direkt prime istediğimizden sadece prime mi yapacaklar? Ready score'la belirtmemiz
Belirtmek
gerekecek.
gerekiyormuş evet.
Hani ona ayrı bir isim yok o zaman. Yani Prime ve Discord diye tek bir ikisini beraber giriş yapacağız o zaman.
Yes.
Mesela işte
Like this is Prime Plus HRD.
tabii tabii.
Hı hı. Hı hı.
Direkt
Masaj
promosyon gidip promosyon gibi bunu vereceğiz.
One question. The cutoff will change, right?
42 değil mi?
Is it
What about
the cutoff?
42.
Is it again 42 or now that it's
We don't know.
I don't
Spiro?
know. I'm not sure about this.
rest of another?
No, why I'm asking this question is because I know that there have been some patients who were rejected after they had Tempus plus HRD
Okay.
score because it was not concordant with the Myriad My Choice. That's the risk in Turkey.
Okay, I will answer to you this because I called Irini, but she's busy now. Okay, when she will call me back. Okay.
Methodology.
Very nice.
Look again in the three parameters.
Hello, it's yes, I think more or less, yes. I don't know the exact.
Here, Tempus is rejected
Hem söyle.
because of the cut.
Bir not al.
And two parameters, okay? Helomeric and most of it heterozygote.
We have all the three parameters in this new panel, right? Because we
Yes.
need three of them. Otherwise, it's going to be rejected by the authorities.
Yes, we have these three parameters, okay, but
Okay.
I'm not sure about the cutoff, okay?
No,
So
the-
I called Irini.
yeah.
Yes, I'm waiting the reply of Irini, okay?
That's LC.
No.
The three parameters that Ready Score comes out is the same with the old one, with
Okay.
exactly the same. Thank you, Irini.
Okay, the same. Nothing changed.
Okay, good.
Perfect.
Okay.
Ve
So, these are very, very good news for Prime.
Very good.
Okay, but please be careful with those 4 types of cancer. If you want my opinion, as Spiro said before, if somebody will ask about having HIV, you want to have a number?
No, I was just
Okay, yeah. If somebody will ask you, I want also for gastric cancer, from colon cancer, HRD. For colon cancer, it's a big discussion, okay? Spiros knows what I'm saying. Okay, forget what I just said. Okay, so if there is, somebody will ask you about gastric cancer, yes, we can provide it. But the thing is, these are the main types of cancer that we should push for HRD.
Okay.
Okay. I don't know, Spiros, if you want to make a clarification here or something, but this is, for me, it's very simple. Okay, it's a very, let's say, strong gun in your hands in order to push for more primes.
correct.
This is
Yes, okay.
the same thing what you said before about prime, about complete breast. This panel is, by the way it is designed, it is selling by itself. Okay, you don't need to say a lot of things. You don't need to say many things. If somebody wants to ask to do something for ovarian cancer or for pancreatic cancer, prime is a perfect tool.
Okay, what about the time?
Because we
Without
don't need to, nothing will change, okay?
Not
Nothing-
change?
Nothing.
Start, you give the prime result plus
For 15 working days, 15 working days.
the same, okay.
And we don't need to forget here that we're also going to provide It's 1000 genes, 1021. Okay. HRD, immunohistochemistry biomarkers, PD-L1, FRA, what else? HER2? Okay. Yes, FRA, yes. And if somebody wants FRA from something else, also, they no, performed and TMB, of course. Okay.
Yeah. Yeah.
So it's a complete crime. It's a complete exam. Okay, well, we're talking about pride, but it's a full. Nothing is missing. If you ask me, the only thing that is missing is MRD. Okay, which is something we're going to discuss it through 2026. Okay.
Okay, guys. So, okay, of course, we could provide this exam previously, but of course, you had to charge the patient with 1,000 euros more, whatever. Okay, now it is easier for the patient, for the physician. It is cheaper, of course. And of course, we can compete all these competitors that you have in Turkey with all these panels from US.
Spiro, just a last comment. Okay,
Yes.
and then I'm not going to speak again. Not a promise, but so we are going to sacrifice HRD for ovarian cancer. Okay. In any case, you didn't have a lot of samples through the year. If I remember well, it's less than 20. Okay. So yes, we will sacrifice some samples, but the only way is to, if we want to cover this loss that we're going to create, you can accelerate with more prime samples in order to fill this gap. Okay, it's in your hands, I think. It's a fair sacrifice. We are sacrificing something small in order to receive something big or bigger. Okay, or at least we are assuming this. The same thing is with breast cancer and prime. We are going to sacrifice maybe the 50 or the 60% of the primes that they were performed in a breast cancer.
Yes.
Okay, because the doctor will choose a cheaper drug because he has all the information that, but we are going to discuss how we're going to differentiate complete breast and prime breast tomorrow, which is something that it would provide to your doctors options. Okay, options.
Options. Şuradan kazanacağız.
Okay.
So when it comes to doing just ReadyScore, are we going to go on and analyze with only BRCA1 and 2, or we will add the other genes?
Here, you can see the other genes, Nesse, here.
So we will have
So-
like Mira and My Choice plus
Yes.
panel.
Yes,
Yes.
in HRD analysis now, if a physician wants only HRD, ReadyScore, we will, whatever, prime with ReadyScore, ReadyScore separately. We provide also the analysis of all the genes here, okay, in somatic level as Myriad, okay.
Is it clear? Will you clear?
Added all other HRD genes, right?
Yes.
Right.
If you want to discuss it 1 minute in Turkish, do that.
Yes,
It-
please.
It needs to be very clear.
Yes.
Okay.
Daha önceden bizde hani ReadyScore BRCA 1-2 somatik sadece içeriyordu. Ama rakip daha geniş bir HRD paneli analiz ediyordu. Bunu daha önceden de defalarca
Evet.
onlarla paylaştık. Yeni güncel ReadyScore panelimiz kaç gün bilmiyorum, sayamıyorum ama HRD genleri hepsini içerecek artık. Sadece BRCA 1-2 somatik olmayacak.
Çok önemli, evet.
How many genes are here in this panel? I cannot read.
Yazmamış. Ama ne fark eder işte, var bayağı işte.
20, 30,
Spiros, help us. You can read it on your screen.
36, 36 fusions.
43 bile.
I think. I don't know.
Aa,
36.
çok güzel.
36 genes.
Yes.
After the
36.
meeting, everyone goes to the icon.
6 vision, 36.
Your screen,
Yes,
You
it's
believe that?
36. Six fusions.
Six fusion. It says fusion.
The blue ones are really bright.
36 artı 6. Çok zordu. 36 artı 6. Ha işte cut-off kadar.
Nice. Very nice name. Alpha 6. Six.
Okay. So 36 genes.
Cut-off number. Okay.
Cut-off 42. Nanos.
36 plus 6. Yeah. So it's the cut-off value. Logical result.
That's the
Fiyatı mı aynı kalacak?
Ha?
Fiyatı aynı.
Mantıkları çok değişik.
No.
What about the
price.
What about
of
the
this?
price?
Just
Money.
yes. Is there any change of Red Score's price?
What do you mean?
No.
Best price.
Best
Is it going
price.
to be changed?
It's also
By itself, as a single.
Yes.
As a single exam.
the same.
You need to make a list with the transfer price and you need to ask. Okay.
No, yes, I know. I don't have to.
Okay, we need to also finalize tomorrow all the things that we're going to, okay, I'm going to talk to Mark here, okay, and speak. No, okay, but, Move.
Ben soruyorsun. bir de soruyorsun.
Move, yes.
Go, please.
Cyrus,
Guys,
this good news, we don't need you anymore.
okay, of course. In my opinion, to promote Ready Score separately in ovarian cancer, it is not a good choice because the difference between Prime plus Ready Score and Ready Score alone is very small. Okay, so now you have the opportunity for all these patients with ovarian cancer, because you had such cases in the past, to have, for example, I remember a case with Prime, Ready Score, and Heredity. Now you have with more affordable price, Ready Score to be included in Prime with no extra charge. So this is incredible news for you and for the patients in Turkey. Okay, so let's continue. So this is about Ready Score. Okay, the key messages, of course, is that with Ready Score, we can simultaneously analyze HRR gene mutation and HRD score in a single assay. But okay, as I told you before, I believe that Prime plus Ready Score is the best tool now. Integrated and streamlined workflow, for all these things that reduces hands-on time and facilitates undefined data interpretation. And about clinical validation is about that we have now an NGS-based HRD testing, has been cross-validated against the myriad by choice results, and we have a very good overall positive agreement with my choice based on this publication. And of course, HRD could be very useful for decision making for some targeted therapies like PARP inhibitors. So let's go to see new reports. Okay, for new reports, we will change new reports. Okay, Dimitris, do you know if the new reports
Today
are
it's going to be finalized.
okay?
But
Just
the
I give
idea is like the thing
Yes.
that you are going to,
Yes.
to present
Okay.
right now.
I will give you an idea now. Now, all the reports that we will provide are based in OncoKB platform. Okay, we are paying OncoKB guys in order, based on the analysis, on the mutation, on the findings, based on OncoKB platform, to have the level of evidence. So the level of evidence now is based on OncoKB platform. I believe in Turkey yet that some other competitors are using OncoKB. Okay, it is not the differences are not so big between the previously level of evidence. The only difference that we have now is that we have OncoKB level of evidence. And for OncoKB level of evidence, we have a level of evidence A if we have an approved therapy, FDA approved therapy. If we have a therapy which is recommended by NCCN guidelines, okay, so we are discussing about level of evidence A, and level of evidence A is also for some biomarkers that we are using for resistance to some FDA approved drug, like for example KRAS mutation. That you have KRAS mutation, you know that you cannot give cetuximab. Okay, so for these three reasons we are using a level of evidence A. Level of evidence A, so to conclude, is FDA approved drugs and biomarkers included in NCCN guidelines. Okay, the level of evidence B, okay, level of evidence B is based only if we have some very good trials indicated that based on this biomarker and this targeted therapy, there is an effectiveness of the drug. So we have the clinical evidence that supports the biomarker as being predictive of response to a drug in this indication. So let's see, for example, now an idea. It is not the finalized report, but like this, we will have the new report. It is more simple for the physician because here in the first column, we will report the biomarker and the specific variant that we identified in our analysis about this biomarker. Based on OncoKB level of evidence, we will have the level of evidence A, approved therapies, or therapies included in NCCN guidelines. The level of evidence B is if we have some well-powered studies to support the effectiveness of the drugs for these specific biomarkers. And level of evidence C, we are discussing for off-label treatment. Is it clear for you? Okay, when we will have the finalized version, of course, we will add this version, the final version, in the presentation that we will see after the lunch that you will use during your visits to physicians in your tablet. So you can, of course, you can explain to the physician the differences, the changes in the reports. It's okay?
Yes.
So there is no column for the clinical trials, am I right?
Yes.
Yes, yes.
Exactly.
We excluded clinical trials because we have, after that, of course, many pages with clinical trials. Okay.
But this is also going to be described in the report, the clinical trials, but they are not going to be added in the first page of the result, which is, let's say, they are causing a lot of noise without any, how can I say that? Meaning, clinical outcome and clinical utility, okay, at least at the beginning, because in any case, the doctors are looking for something in order to use which is on label or something like that, okay? But this, the second line, the second column with OncoKB, with the current result that we have, that we're running the samples right now, it's going to be analyzed in the, I don't know which page, third page, fourth page, something like that. Okay.
Okay. Also in the first page, we will mention the CAP accreditation that we have. Okay, here you can see. And the ISO that we have also, ISO 9001, ISO 27001, all these ISO. So from the physician, for the physician and the patient to understand that this exam was done in a reliable lab in Athens. Okay. Okay, about complete, I'm leaving complete. And let's go to the final part called exome RNA. So to conclude with new reports, you will be informed. The concept is that we will use OncoKB, and the level of evidence that we will provide will be interpreted by OncoKB. Okay. So let's see whole exome RNA. For whole exome RNA, now, because based on T7, now we have the possibility, the opportunity to run RNA exome sequencing. We will have the addition of RNA sequencing in PRIME in 2026. Okay, we will discuss then this because we have so much information now in lab in Athens. They are working very hard now in order to implement all these changes very soon. So for PRIME, because you know that like Foundation One, we are doing for fusions, okay, rearrangements, we are doing DNA sequencing. Okay, we have some pros and cons, of course, for this. Now, in 2026, we will have the ability to add RNA sequencing for some fusions. We will discuss then. Until then, there is no reason to discuss RNA exome sequencing. I will give you when to discuss RNA exome sequencing. So surely in 2026, we will have the ability to add RNA sequencing in PRIME, so to have a very, very good, a better test. The best test, because now we will give also all these fusions by DNA and RNA sequencing. But until then, okay, because we are discussing about fusions, we are discussing about MET exon 14 skipping mutation. I'm not going to discuss about future. There's no reason now to discuss about this. The only reason now that we are discussing about RNA exome sequencing is about sarcomas, guys. Okay, because previously we thought we had a limited panel about sarcoma fusions. We will have the same panel with the same price, but now we will do RNA exome sequencing. So in this case, we will provide all the information that a physician wants for a patient with a sarcoma. Okay, and for sarcoma, whole exome RNA sequencing, we have so many fusions, important, very important, in the not only in the management of the patient, mainly for the diagnosis of the patient. So now we have the ability to do the right exam for all these patients with sarcoma. Sarcoma fusions now is upgraded, doing whole exome RNA sequencing. For the addition
When we
of
will
RNA
start
sequencing.
providing it? Since when can we order this panel?
From Monday.
About diagnosis from Monday.
Monday.
Sorry, Neşe anlatabilir misin hepimize?
Normalde sistemde daha önceden küçük bir sarkoma panelimiz mevcuttu. Şimdi o küçük sarkoma panelini aslında RNA bazlı ve tüm egzom sekanslamana bağlı geniş bir paneli kapsamış.
Artık sarkom panelimiz var diyor.
Yani daha önceden sistemde küçük bir sarkoma.
Besimiz var zaten.
Efendim?
Besimiz yok mu elimizde? Full exome sequencing.
Şimdi besimiz DNA üzerinde bu, RNA üzerinde.
Bu RNA üzerinde olunca sadece sarkomla mı?
Sarkomanın özellikle tanımda kullanılan.
Diagnosisleri, evet, tanı.
Şey diyebilecek miyiz?
Sarkomda.
RNA ve RNA bazlı bir test.
Yok, bu ayrı bir test. Şimdilik ayrıyetten isteyebilirsiniz. Sarkom için çözüm olarak size prime artı RNA egzom testi sunabiliriz. İki ayrı.
Prime artı bu olarak şey yapabiliyor olacağız sarkom için. Anlaş.
Tek testi sarkomda istiyorlar böyle.
Evet,
Diagnosis içinmiş bu.
Yapıyorlar. İstiyorlar.
Mustafa Hoca bunu mu istiyor bilmiyorum.
Evet. Bunu istiyorum.
Sarkom.
Ben hazır.
Bana.
Pazartesi var mı?
Bizim daha
ne
önce
şey-
sarkoma füzyon panelimiz mevcutmuş. Bakalım bu sene kaç tane gelmiş.
Geldiğini sanmıyorum ya.
Yok, bir sene hiç gelmemiş.
Yok.
Ama daha önceden bunu zamanında birkaç girişim
Bir
vardı.
iki tane bir sorun oldu, etti bilmem ne
O
yapıldı.
Reyna tabanlı değildi ama değil mi?
Hayır, o da Reyna'ydı. Evet, şimdiye kadar toplam 3 tane order
Hı.
almışız arkadaşlar. 2014, 22, 24. Bunları Özcan Yıldız Nurullah Zengin ve Ferhan Fulden Yumuk.
Vay be. Gülden Hoca nasıl bizden böyle bir şey istemiş, şaşkınım.
Şey olarak yani böyle birkaç koçta olmadığı zaman alternatif olarak şey yapıyor ya istiyor.
Kullanınca şaşırmışsın.
Nurullah Hoca'nın kafası karışmıştır kesin yani. Anlamamıştır da nasıl onu.
We checked the system till now we had only 3 sarcoma fusion NGS panel until now. But regarding the diagnosis for sarcoma, Mustafa Ozdan had this kind of request. So this is
But-
something that directly can serve to this.
But this is not only for Usogan. Okay, there are two things that we need to, to put. First of all, it's a new exam. Okay, with the same cost, nothing will change. It is going to be a whole RNA exome sequencing, and we are going to cover all the possible answers, all the possible, I don't know, things that it could come out, and cover this need for diagnosis for the sarcoma. There are, I don't know how many sarcomas they are, but there is a need. This is why Ostogan is pushing a lot about sarcomas, diagnosis. There is a need for diagnosis in sarcoma. So yes, we had 3 exams about sarcoma fusions, but I don't think that you spend a lot of time on the field discussing about sarcoma fusions exam.
Çünkü sarkomların zaten görülme yüzdesi tüm tümörler içerisinde %2 civarı.
Evet, hem çok az hem
This is a
Sanki
new
bakan
exam
doktor da
for
az.
you. This is a new exam.
yes.
But this is a very, very helpful exam, believe me. If you're going to have a discussion with your doctors, you will find out that this is a very useful tool for them, not for which treatment they are going to follow, about diagnosis.
Hı hı. Understood.
Okay, and which is one of the most important things before the treatment. Okay.
Of course.
If they have the right diagnosis, they could treat their patients the right way.
Okay, so sorry. Okay, and in the future, we will have also from 2026. Maybe you know that in some panels for hereditary cancer, from some very famous labs worldwide, like Ambry Genetics, Invitae, Myriad, they are using also RNA sequencing for some clinical purposes in order to reclassify VUS. And okay, we have a publication for some splicing variants to be categorized by RNA sequencing, but now we have the possibility in heredity. But just for this information, because we will do it from 2026, after 2026, to add RNA sequencing in heredity. Okay, so in 2026, we will have the possibility, the ability to add RNA sequencing in prime, in order to do for fusions the comprehensive approach, DNA RNA sequencing, and we will add also RNA sequencing in heredity in order for to have a complementary tool for some suspecting germline variants, especially those affecting splicing or expression. Okay.
Just a minute, Spiro. Neşe bize bunu anlatır mısın ya?
Şu nasıl gelecek olan şeyler.
Şubat ayından sonra bu RNA egzom analizi diğer panellere, kalıtsal hereditary paneli gibi panellerde dahil edileceğini, bazı kalıtsal sendromlarda DNA'da görülmeyip de RNA üzerinde görülebilme olasılığı var.
Rhino da entegre edecek.
Is this going to happen in the beginning of 2026? Okay.
Yes.
Okay, within a couple of months. Herkes anladı
Yes,
mı
okay.
bunu? Okey.
Gelecekse de şey diyeceğiz.
Aynen RNA'da bakıyoruz diyeceğiz. Evet, aynen öyle. O that's important for us. Yeah.
And plus RNA-based
Benim
testing.
ayrı bir istek mi olacaksın?
Yok, hayır. O öyle bakılıyor olacak.
Okay, based on publication, based on literature, this will add another 1.5 to 2% pathogenic mutations, germline pathogenic mutation.
Hmm.
Okay,
Hmm.
this is very important for, I don't know, for family histories which are very strong, and
Yes.
we are doing hereditary cancer, and we
Nothing
are
comes up.
we're doing heredity, which is, by the way, an amazing exam, but at the end of the day, the ability of this exam ends to DNA level. Okay, so if we want to, let's say, to move forward, and if we want to analyze in a deeper way, in more depth, okay, this is the thing that we're going to do. And this is going to be a new exam also, which is going to be performed in after the result of heredity. Or maybe it could be asked from the beginning, but if you want my opinion, there is no need for somebody to ask this exam from the beginning. Okay, we need to see which is going to be the result from heredity, first of all, and then we should move if, after the discussion with this lady here, the doctor could push the patient in order to pay another 300 euros or something like that and move forward to this analysis.
Especially
You are
minus
having a strong family history, and
This is
also
something, yes.
indications, and you perform heredity and you are having a negative results, then in this cases, doctor can go on.
Anladınız değil
And
mi?
something, and the more rare situation for the more rare situation is when you have a finding which is boost, but it plays a strong role to, oh fuck, I'm going to destroy that in English. I don't know how to say it. To how it works in the example of the protein, how the protein is used. Yes, perfect. Okay, so maybe that thing, I don't know, maybe once in a year, twice in a year, that people from the lab ask you for more blood in order to clarify if this mutation is boost or because this finding plays a strong role to, tell me again, how you say,
Protein expression level.
protein expression level, it gives to them the message that we should look in more depth what is happening with this finding. Okay, this is also something that it would be very useful, but it's a rare situation, that thing. This is happening, I don't know, 5, 6, 10 times per year. Okay,
Or maybe,
especially my risk asked by the doctors many times to me, do you have a test like my risk?
maybe we can.
my risk is immediate.
Yeah.
Yes.
Okay,
So maybe we can make our heritage in two options, exclusive heritage, then that will be more in price, but the doctor can screen everything, both of them.
Option.
Option,
from the beginning.
yes.
Let's see. Yes. This is just a future. This is something. This is a discussion we're doing right now for something. It will happen after 3-4 months.
Okay, yes.
It's
For the
good
next
for us to do. The thing is that you understood how important that thing that we could provide also. All the big global players in the world, they are providing this information. So we are going to be also, there are not many labs that they can do that thing. This is what I'm trying to say. And this is the thing that you could keep from the whole meeting, because for me is the most important meeting that we have done in the past, I don't know, 3-4 years. Okay, we are changing completely direction as a lab. Okay, we can perform exams that they are performed from, I don't know, from not many labs in the world. Okay, all this portfolio that we could provide is very, very, very, very important. Okay. So, Spiro.
Okay. So, just a moment to unshare, just a moment. Okay. I want to give you, for example, okay, in 2021, for this RNA sequencing that we will provide in heredity, we have a publication for the clinical utility of functional RNA analysis for the classification of splicing gene variants in hereditary cancer. So this publication was our publication, and the conclusion here was that okay, this that Dimitris mentioned before. In some cases, they are asking from the lab to send another blood sample. So with this, we did the classification of these splicing variants, and 20% of splicing variants from VUS to be upgraded to pathogenic. Okay, but okay, this is a publication for some work that we've done previously in the past. Now we will have this RNA sequencing to run simultaneously, or in some cases that we have a very strange negative report for a patient with a very strong family history. So we have now this not to run this methodology after that, to run simultaneously. So okay, guys. So let's continue. Are you okay?
Yes, yes.
Okay, good.
Kalimayı birazcık şey yapsak ya. Bassınlar böyle bir havalanalım.
So, guys, we
Spiro,
will do.
sorry for just give me one second. Do you know what that thing is? This is not a person. This is an AI tool that is going to create a summary from all this meeting, and it will be sent to you. Okay, so
Very nice.
we're using the Microsoft AI tool, and then it will come back to you with all the information, just a summary, what we discussed and all these things. Okay,
Very nice.
Perfect.
but it's going to be many pages if you want this, because it's a long meeting. Okay,
Of
this one.
course.
This is Barcelona.
You know. By the way, should we order lunch? Because it's
How this thing, how this thing.
acıkmadınız mı ya?
Yok.
Everybody is hungry and I'm speaking for
Okay, do whatever you want. Spiros, can you please give us 5 minutes in order to
Yes.
order?
Yes,
Okay,
yes.
Sorry about that. Okay.
Just inform
Sorry.
me when you are ready. Okay.
Okay. Birincisi açız. İkincisi zaten 6'da yemeğe gideceğiz. Tekrar acıkmak için zamana ihtiyacımız olacak yani. Hani ben öyle düşün.
Çok kalmasın.
Yoksa acıkamayız ve akşamın tadını
Bence
çıkaramayız.
hafif böyle salata gibi bir şey yiyelim. Salata.
Evet.
Yine
Salata mı? Ama salatayı seçmek çok zaman alıyor abiciğim.
bunu istiyorlar, bunu istiyorlar.
Evet abi.
herkes tavuklu salata yesin.
Bir şey geldi.
Herkes tavuklu salata yesin.
Ya ne salatası ya? Karı gibi. Evet ya bir
Abi bak,
döner
sen-
mesela. Döner abi. Herkes döner değil mi?
Durum
Tamam.
basit bir şey.
Ya herkes ediyor.
Şu şeyden saray mıydı Neşe bizim söylediğimiz yer ya?
Yok.
Yanlış mı söyledim? Hayır böyle.
Ya şimdi
Ay, nereden Neşe?
Döner plastan.
Döner plastan.
Döner plastan mı söylüyoruz? O zaman hadi herkes parmak kaldırsın. Durum olarak mı?
Onlar başladı.
7, 8, 9,
Şahane.
10, limiti 11. Kızlara söylesene 11 tane döner plus. Dürüm döner plus.
Yani birden fazla.
Hayır sonuçta herkes acıklı.
Yine ben de sarkomda.
Abi niye sana konu yıllarında?
Ne?
Bazı yerleri dinlemedim de. Olur falan. Şimdi sorayım.
Bir de bunun itiraf mı ediyorsun? Bazı yerlerde kafam attı dinlemedim anasını satayım.
Yemin ediyorum.
Yani özellikle
Hayır. Söyleyecek birden fazla.
Ha onu tuttum.
Light olan izlenebilecek.
Sağlığı yerinde olur.
Kolacılar parmak kaldırsın.
Ne isteyenlerde beni dinlemiyor.
Light.
Fark et.
Ya fark etmez artık. Bu kadar şey.
kola kola.
Ayrancılar parmak
Ben
kaldırsın.
de dinlemiyorum dersi.
Gerek yok.
Ben-
Sen parmak kaldırsın.
Ayran
Kola.
gerek yok.
Soruyu anlamadım.
Kola içmiyorum.
Kola tek
Kola
kola
ayran
ayran
mı?
peki.
Kola.
Yani şimdi ben kola içmiyor. Ben kola içiyorum. Kola istemiyorum.
2 ayran birisi kola herhalde.
Bir tanesi kilo olsun şerbet.
3 tane.
Ortalık karışmasın diye herkes feragat etti şeyinden. Kendi özel zevkinden ama olsun ne olursa olsun. Demek ki herkes acıkmış arkadaş. Güldünüz ettiniz ama.
Nefes alamıyoruz ya.
Bu karbonhidrat şekeri tekrar coşturuyor.
Zaten aynı habire aç geziyorum. Hem yiyorum hem acıkıyorum. Hem yiyorum hem acıkıyorum.
Tatlı, tatlının üstüne tuzlu. Sonra tekrar bir tatlı. İğrenç bir döngü.
Spiro, give us 5 more minutes, okay? Zaten gitmiş. Hadi hemen bir sigara içelim.
Zaten bitmiş.
Şey ne diyor?
Bir salata yiyelim.
Dersi dinlemeyen arkadaşımız ne diyor? Ben zaten oraları dinlemedim ama.
O da Sarkon'da kalmış.
O da sarkımda kalmış.
Burada bir endikasyon ya. Bir daha sabah konuştuk. Kuru Üniversitesi'nde bir hoca sarkom olmuş. Daha yeni ameliyat oldu da. Oraya takıldı o.
Abi Sarkon.
Ya ben domatesi söyleyeceğim. Ben şimdi pazartesi başlayacak gibi algıladım. Sen doğru bildin.
Hangisi için?
Şimdi bana bir tane bugün sabah Rediscore geldi de pazartesi günü bunların test sonuçları Rediscore böyle mi gidecek o zaman bu durumda? Bak
O Prime'ın
tamam.
test sonuçları değişti.
Sadece Rediscore olanın mı değişiyor ama?
Rediscore olanın
Ona da folat reseptörü yükleyelim demişti. Şimdi eğer öyle ben bunu
bugün
Prime
gönderme.
çevireyim. Değil mi?
Çevirebiliyorsan Prime
Çevireyim.
2900 lira alacaksın.
O da
Diğer
ayrı.
türlü
Öbür
1800
türlü
lira
de
alacaksın.
ona bakarsan da de var. 275 Euro'da folat reseptörü var.
Prime yaparsan içinde olacak. 800 2000 yapacak. Yine 2900
Yani
alacaksın.
çok fark var. Evet. Yok. Kurtarmaz. Durup dururken 200. Ha şu da var. Tamam bunun hepsini görsek da versin parayı da diyebilir. Belki adam zengin onu da bilmiyorum.
Ha bak öyle bir şey varsa direkt Prime yaptır. Artı Rediscore'u eklet yanına. Beleş.
Ya da Rediscore ya yazıştık da adamla ya şimdi. Rediscore
Tamam, şimdi bir toplantıdayım. Konuda bilgi alırım. Ha.
Of. Gerçekten çok interesting bir gün oluyor.
Şunu halledelim.
O
If you are ready,
bir şey eklesek
we
olur
can
mu?
continue.
We have a
Are you
break.
ready?
No. We all are in break. Çok pardon bir saniye. Spiros, we all are in break for 5 minutes. Okay.
Okay. Just for me.
Okay, see you bye. Kusura bakmayın, bir toplantıdayız. Biz de uluslararası bir toplantıdayız. Şimdi gönderdiğinizi gördüm. Bu yeni tanı olmadığı için tekrar buna bir her iki ideal var. Yani içerisinde her şeyin olduğu hoca da işaretlemiş zaten fosforluyla. Şimdi bu testin fiyatı 1320 euro. Ne yapar? 64 bin lira gibi bir şey yapar. TL'ye karşılığı. Şimdi Kars'tan gönderdiğinizde birkaç günde İstanbul'da oluşuyor. İstanbul'dan toplamda bir hafta kargo süreci sürüyor ama 10 iş gününde de sonucu çıkıyor. Genellikle erken çıkar, onu söyleyeyim. Hani Çiğdem Hoca'nın hastalarından bildiğim kadarıyla. Bunun için bize parafin bloklar lazım. Hastanın tümör dokusu lazım. Eğer bunlar için okeyseniz size bir form göndermem lazım. O formu hastanın doldurması gerekiyor. Siz bana göndermişsiniz. Elinizdeki bütün patolojileri de gönderin. Efendim? Bu kadar mı var? Tamam. Önemli değil. Gerekirse ben Çiğdem Hoca'dan destek alırım bu konuyla ilgili. Şimdi bu dar panel bir akciğer testi ama sizin hastanızın bütün ihtiyaçlarını karşılar. Yani daha büyük paneller var böyle 2900 euro. Yani 3200 euro testlerimiz var ama gerek yok gözüküyor bu hastada. Zaten Çiğdem Hoca bu konuda çok yetkindir. O da dar panel tercih etmiş. Yani bundan sonrasını yazışarak ilerleyelim. Ben size bir form göndereceğim. O formu hastanın doldurması gerekiyor. Size bir kargo adresi göndereceğim. Alacağınız tümörün niteliğiyle ilgili bir renkli bir form göndereceğim. Takıldığınız yerleri sorun bana. Ben bugün ve yarın İstanbul'dayım. Laboratuvardayım. 2 gün toplantı var burada. Yazışarak ilerleyelim. Çünkü aradığınızda ulaşamayabilirsiniz. Birazdan bir sunum yapacağım filan. Eğer okey derseniz sürecin Buyurun. Bunda taksit olmuyor. Peşin ödeniyor ama bir miktar indirim uygulayabilirim buna. Onu hesaplayıp yazayım size, olur mu? Yani elimden gelen ne varsa. Çünkü ben Çiğdem Hoca'yı çok eski tanırım. O da sağ olsun hani bizim laboratuvar, biz uluslararası bir laboratuvarız. Çok sonuçlarımıza güvendiği için gönderiyor. Şimdiye kadar hiç mahcup olmadım çok şükür. Elimden gelen ne varsa bir bakayım yapayım, olur mu? Yazayım size bunların hepsini. Tamam, görüşürüz. Hoşçakalın. 1320. 1320 eksi 130 olsa 1300. Sıcağı sıcağına hemen söyleyeyim. 1320 euro yaklaşık 65 bin lira yapıyor. Sekiz bin. Yani yaklaşık %10'luk euro bazında bir indirim yapabilirim. Maksimum.
Biliyorum konuşuruz sonra. Hadi.
Siz yine lütfen araştırın. Kararınızı verdiğinizde bana haber verin. Ben size formları göndereyim. Tamam. Bir tane Prime Lang geldi. Bakalım. Şunu kapatalım ya sesini.
Alacağın şey.
Nobody must make it.
Ya
Really?
en ucuzunu alıyor. Mecburen altına bant falan yapıştırdım. Hiç çalışmak için habire vurmam gerekiyor. Yeni yani. Ha,
O
bir
yüzden
aylık
onun için
falan.
Ben de bir şey
Ne bileyim yeri o. Ha, bir çıkarıyorum kapağı düşmüş. Çantada kapak arıyorum falan.
Ha, o yüzden yapıştırdın tamam.
Kim kadar yapıştırdı sağ olsun.
Ama tam Türkiye'ce televizyonla böyle göstermek kafasına koyuyorsun ya.
Pınar en ucuzunu alıyor. Bant yapıştırdım. En son aldığım mouse. Mouse alacaksan git kendin al abi.
Şey okunuyor mu diye yoksa
Kapağı düşüyor lap diye. Hep vurmam gerekiyor çalıştırmak için.
bu da aynı. Çoğu zaman da okumuyor zaten.
Zaten bu arada bende de mesela benimki
Bana pembe mouse getirir diye pembe getirdi.
Ya
Gayet de hiçbir şey olmadı.
benimki de
Sefadan
bir şey değil.
izleyeceğiz.
Bu da belli bir süre sonra kendi şey alıyor galiba. Tekrar bir şey yapmak gerekiyor.
Fotoğraf kağıdı.
Müge Hanım arsenik yani benim.
Şimdi güncelliyorum.
353.
az önce
O
söyledim.
1999.
Ay beni de Memorial'dan aradılar. Yabancı bir hastamız var Moldova'da Onkotay.
Yalnız biz
Bahçeli'nden.
Ha.
biz Eda ile Memoria'da ama Şişli'de çok güzel şey oldu, denk geldi.
Ne?
Hoca ile içeriye görüşmeye gittiğimizde sana elinde komplet raporuyla konuşuyor.
Evet, lang raporu.
Lang raporuyla.
Hangi hoca?
Neydi?
Serkan Keskin. Ama ona büyük ihtimalle o başka bir yerde yapıldı. Hocaya danışmak
O
için geldi. Dosya
bir
tarzı.
şekilde falan göndermez çünkü.
Kurumdan göndermeyiz ama kurumda şey üzerinden
Kurum-
oluyor.
Kurumdan komplit gelmez. Kurumda komplit yok çünkü. Sadece Prime var.
Kompletten raporu var.
Evet abi.
Şurada olabilir mi?
Yani
Beş yani.
Neyin
Şey
22
olabilir mi?
gözüküyor?
Kendinki diye almış olabilir mi?
Olabilir.
Senin 8 tane Oncotype'ın var.
Şu anda
Ben evet abi şu anda
Benim
Oncotype
kaç görünüyor?
çekiyorum.
Bir tane daha geldi.
5.
O da bir hafta takır takır 5'i geldi sonra yok ya.
is it good like this?
Bir tane şimdi şey geldi.
Bunu
Aşağıda
telefonum
burası.
bende kayıp değil.
Doğru ya.
Demin bana verdin. Ona bakıyordum. Sonra laf karıştı. Bakmayı unuttum.
Sen doğru onu gösterdin Müge Hanım'a.
Ya Şadi çağırsana milleti.
şey seçmeye
İşte
çalışıyorlar.
başlayalım artık.
Bir nur. Ne diyeyim Bekir?
Nerede senin ekürü? 06.
Benim orada ya. Benim.
Hadi başlıyoruz diye seslen bari de şimdi sinirlenmesin. Tuvalette mi kaldı?
Yanlış Hanım'ın odasında.
Evet. Onun bir yöntemi var. Should we continue?
Yes.
Spiro, are you there?
Yes, I'm here. So-
I just sent you a mail.
Yes, okay, about sarcoma fusions and Osdogan, okay.
Yeah. You can translate it from the Google directly, so you can see whether which one,
Okay.
because it has a detailed analysis, which methodology used, whether it has the RNA analysis, etc.
Okay. So, guys, we will do a change in our agenda before the lunch that you will have. Let's see now the key messages of our meeting. And after the lunch, we will discuss about the competition. We will discuss about prime statistics or prime case reports if you want, maybe to do it in another meeting in the future, or to see also the brochures, because in the brochures we don't have so many changes. I will focus just only the changes that we have in our brochure. So, in my opinion, this is the most important part of our training, okay, the key messages. Now we are in the T7 era, okay, T7 era, because we have now T7, and for this reason we have the ability to do all these changes and to do all these exams, okay, RNA sequencing, whole genome sequencing that Dimitra Buzarelu will tell you tomorrow, that all these are amazing tools for us and to increase, of course, our work. So let's start with the key messages. Dimitra Buzarelu will tell you tomorrow about T7, that now, okay, we can provide, of course, whole genome sequencing. And believe me, there are very few labs in Europe to provide whole genome sequencing. For example, for some cases, many labs are sending the samples in Europe, in some labs in Europe to provide whole genome sequencing. So now we will do, and you will discuss with Dimitris tomorrow to expand maybe collaboration with other labs in Turkey in order, of course, to have us outsourcing partners for whole genome sequencing, because if you can provide whole genome sequencing, you can provide whole genome sequencing for many patients and many cases, okay? So, take-home messages that you will discuss tomorrow about T7 era. Now we have this new sequencing platform, and of course it is very important. We upgraded already our targeted panels. Okay, we upgraded Complete DX Lung, Complete DX Colon, Complete DX Breast. We upgraded Prime, okay, because also the addition of ReadyScore in Prime, it is an upgrade. About whole genome sequencing, it is the only lab in Greece. There is no other lab in Greece. One of the few in Europe, and of course, we can reduce the turnaround time. Of course, this is not for the time being, but in the future, if we can increase, okay, double, triple our samples, maybe we will see in the future maybe to decrease also the turnaround time. We have the ability now to do, and Dimitra Buzarelu will tell you tomorrow about whole exome sequencing in some rare phenotypes. So ClinCore, we will not have ClinCore now. We will have whole exome sequencing with the same price, but of course it is an upgraded test now. And of course, as we discussed previously, whole exome RNA sequencing, that we will have the ability to add on Prime, to add on Heredity, starting from the beginning of 2026. So let's go to key messages that we discussed during this training meeting. Complete DX Lung. Okay, this is our panel. Okay, we added Energy One as fusion. We added FGFR as emerging biomarker as fusion. So we provide all this information, and this is a comprehensive, of course, information for any patients with non-small cell lung cancer. We have now Complete DX Liquid, because previously we didn't have the opportunity to provide a liquid test for lung cancer patient, except prime, because the panel that we have previously, we had previously Complete DX lung liquid. It was a very small panel with many missing genes there. Now we provide the full information, okay, using another panel than the previous one, but we can provide all these genes, DNA sequencing, RNA sequencing, plus MSI, all these approved prognostic and emerging biomarkers in liquid biopsy. And this is amazing, guys, now, in my opinion. Complete DX liquid is an amazing tool for non-small cell lung cancer. In the initial diagnosis, in a relapse setting, it could be very, very useful.
Spiro, can you go back to here to complete liquid? You said about the small panel that we used to have as a complete liquid panel. Okay, this was 12 genes,
Yes.
8 DNA, and 3 fusions, correct?
Yes.
Okay, perfect. So if we go back 3 years ago, correct, we had a bigger panel, which was 50 genes and 12 fusions, correct?
Yes.
I remember. Okay, so the difference, because okay, it was 50 genes and 12, now it's 64 and 9 fusions. It's not based on the number. The thing is that the previous big panel, complete comprehensive liquid that we used to have, is the cost not only for the lab, but also, which is smaller now with this new platform that we are going to use. But we're going to give this, let's say, less cost, smaller cost that we have right now in the lab. We're going to move to the market for the patient. Okay, so the patient, if I remember well, the price for the previous big panel that we used to have 3 years ago, even we stopped it when we launched Prime Liquid, okay, it was almost 1,000 euros. Now we are going to have a smaller, a bigger panel with more genes, with better validity, CIVD, with a smaller cost for the patient, for the lab, and smaller cost for the patient also. So this is something very beautiful for us and for the patient. Okay.
Yes, sorry. Something I will ask the team. Akciğerde likit paneli yapılan bir şey var mı devlette çözüm?
Yok, genelde ikinci soruyorlar zaten.
Ha?
EGFR'ler şeylerde real time'da olarak bakma zorunluluğu var. Ama sadece tek geri bakılması. Bütün panele bakmıyor.
Yani şu an kamuda likit yapıyorlar. Yani
Akciğer küçük böyle şey iyi yapılıyor.
Mesela Ankara Sanatoryum bana sadece likit soruyor. Biz likit bakamıyoruz diyor.
Ha.
Elbis bakıyoruz ama likit yok diyor.
eğer bazı yerlerde yapamıyorlar. Yani
Her yerde yapılıyor o zaman.
Katü bakıyor. Katü maşallah.
Üniversitelerde bakıyorlar.
üniversitelerde kesin bakıyor.
Üniversitelerde var ama devlette bir tık şey.
O tabii.
Otururken burası bakmıyor.
Paşa'da da yok diyebiliyorum.
University centers, they will do for them.
Okay.
Either as a single gene or as a panel. But in the state hospitals in general, they cannot provide. In university hospital, yes, but in the normal one, no. So
In any case, we didn't discover the wheel or the fire or whatever. Okay, but this is something that maybe also the competitions are doing that. But you need also to consider the validity of the test. You need also to consider the experience of the lab. You need also to consider that it's a CIVD test. You need also to consider the TAT that we are providing. For the complete DX liquid is going to be 10 working days. I don't know if the university labs are providing this TAT as a clinical use. You need to verify that thing because that thing is very crucial for the
Yes,
patient.
we need to ask all our centers how many genes are involved, the TAT and everything. Okay. Yani bunu promote etmek için her yerde nerede çözüm var, kaç günde çözümlüyor, kaç tane geni ihtimal ediyor öğrenip ona göre.
We will discuss all these things later. Just take notes about the things that you have in your mind, and we are going to have a huge
Yes.
discussion
Mhm.
how we are and what we are going to say. This is an amazing presentation. Spiros is going to show to you right now. Okay, with all the highlights, with all the let's say the useful information that we have right now. But at the end of the day, we need to put this presentation in our market here. Okay, and maybe we will find other advantages that maybe it's not for Greece, it's not for Romania, it's not for the other countries, but it can work here. Okay, so this is why we need all of you to be active later. Okay, be alive. So this is why we're trying to feed you in order to keep you alive and not to lose you. Okay, Spiro, sorry for interrupting
Okay.
again.
So guys, okay, and let's go now to this tool that is amazing, Complete DX Combo. Okay, use this slide, guys. Okay, this is from guidelines that, okay, we are discussing, just to repeat this, we are discussing for false negative rate of liquid biopsy, but surely the tissue biopsy is the gold standard, but surely it is also, there is a false negative rate in tissue biopsy. So to combine tissue and liquid biopsy is recommended by NCCN guidelines in order to reduce turnaround time and increase yield of target alteration detection. Okay, so based on
Spiro,
Yes.
can you please go back?
Yes.
Also, there are some disadvantages here that they are mentioned about the limitations of ctDNA. I think this is something also that we need to discuss with the doctors, because we do know that there are some limitations. It's not the gold standard methodology, but not sometimes, many times, ctDNA sequencing is very helpful for practical reasons. Okay, so this is why we need to have a discussion. We know the limitations, but also it's a very useful tool for many cases and for many lung cancer patients, especially for lung cancer patients. Okay.
Spiros, a couple of questions. Like in prime, when we do not detect anything in any somatic findings
No.
in prime, what about complete?
No.
No? Okay. So we can give a report with nothing. Also, when it comes to lung,
No, the thing is, it's not going to be repeated free of charge. If you are,
Okay.
if this was
Yeah,
the
and-
question. Okay.
and regarding chip mutations, how you are going to exclude them from the liquids complete? No chip, you are having the other one. Okay, so much. Let's ask on the other way. Does any of the chip mutations affect the genes that we are including into the panels?
Yes, okay, you are right about
Okay.
this. I think in this panel we don't have the possibility, like in Prime, to exclude chip mutation. But okay, about
But when it comes to chip, there are the other genes. There are so many genes that are also included into the prime, so that's why you have to exclude it. Now in this panel, in this account of genes, there any that matter into the chip mutations?
okay,
Am I clear?
Yes, sure.
yes, okay, we have to see this maybe in the future to see about chip mutation in this small panel. Okay, but chip mutation, just to remind you that chip mutation are crucial in prostate cancer because we are discussing about elderly people. Here, I'm not sure because about chip mutation, we have some specific chip mutation. Okay, some genes I cannot axe in whatever genes and other. But for non-small cell lung cancer, okay, it is important, but not so important as prostate cancer. But okay, I keep this question to discuss with Irini if we have any possibility to see chip mutation. Okay.
Or maybe we can state that in this panel regarding these genes, there is no risk into the putting account chip analysis, genes, exclusion, etc.
Yes, okay, I have to clarify this. Okay, I don't have this information now. Okay, good questions. Very good question. Okay, guys. Okay, we know generally worldwide liquid biopsy is not used so much due to all these limitations, because in some cases we know that the most important limitation is the undetectable ctDNA, and we know cases, from PRIME that we have a negative result, not negative result, we could not detect ctDNA. In this case, of course, if we, it's too early to discuss all these things. I don't want to give you ideas now, I don't want to confuse you, but just keep in mind that complete DX combo based on guidelines is very useful, is suggested by NCCN guidelines. Try to gather samples, and after that, we have to see the statistical analysis of these samples, and we will see what to do. We have ideas in Greece to have a registry. We will see maybe in Turkey to have a registry for some centers in order to provide complete DX combo. In some cases, to follow up the patients, whatever, we will see. The only thing I want from you to remind you, just please concentrate all the questions from the physicians, all the obstacles. We need your feedback about complete DX lag liquid, about complete DX lag combo, in order to see all these arguments, in order to face these arguments from the physicians, okay? Because it is our first time to have such a panel, okay, so focused, having tissue and liquid biopsy in the initial diagnosis. Okay, just concentrate all the problems that you will see, you will face in the field. Okay. So just a moment to see the key messages, and after that, just ask me whatever you want. Okay, because I don't want to give you answers based on key messages. For this reason, also in guidelines, it is suggested to do concurrent testing of liquid biopsy and tissue biopsy. So we have, guys, this panel, combo, complete DX combo, which in my opinion it is an amazing tool in the initial diagnosis of non-small cell lung cancer. And here are take-home messages. Okay, we have now upgrade this panel. In tissue, we have this 91 gene variant assay with 18 fusion included. In liquid biopsy, we have a 73 gene variant assay with 9 fusion included, and MSI also. It is the most yes, please.
Okay. Nothing.
Okay. It is the most specific molecular profiling with clinical application for prediction for targeted therapies. All the 9 genes with FDA-approved targeted therapies are included here. We added also NRG1 additionally from the previous version. FGFR is included as an emerging biomarker. RNA sequencing, guys. Okay, if you want to ask to the centers like you discussed before, to ask from some centers which is the turnaround time about liquid biopsy, which genes are included in your panel, whatever. The most important questions is this: are you doing RNA sequencing for fusions or not? Because okay, in a bigger panel like PRIME, if you detect 1,000 genes having DNA sequencing, but here with PRIME we know that we have a very ultra sensitive panel. In this case, okay, maybe you lose some few information, but you can detect some fusions by DNA sequencing. In smaller panel, there is no possibility to detect fusions by DNA sequencing, okay, in small panels. So in this case, if you have whatever, single gene testing, small panels, free of charge, in all these centers. Just the most important question, are you doing RNA sequencing? Okay. So for complete DX lung in tissue, we have now our pathologist lab. So we added also HER2 and c-MET and PD-L1 by immunohistochemistry. So we provide the most comprehensive information for all the patients based on biomarker testing and based on immunohistochemical testing. OncoKB report now, we are paying OncoKB. OncoKB is a platform which is, okay, the majority of oncologists, they know OncoKB, and the reports will be provided based on OncoKB level of evidence. And about complete DX lung combo, if I need two phrases to use to a physician, okay, doctor, I have this panel with all the genes in 10 working days. So with enhanced sensitivity, because you know very well that, okay, if you combine tissue and liquid biopsy, non-small cell lung cancer, you can increase the positivity rate and reduce that. And this is amazing also because we are discussing, and you know very well with your experience, that if you have a patient with non-small cell lung cancer, whatever is the panel that the physician will ask, prime, complete previously, you know, surely the majority of times the physician will tell you, okay, Zeynep, Ravi, Sadi, Eda, please hurry, I need a fast result. Okay, why? Because we know that there is in the diagnosis of non-small cell lung cancer, we have many delays until to have the biopsy. And of course, there is, we need to have a fast result. In this case, if you combine tissue and liquid biopsy, in the case that you have maybe an inadequate tissue, or you have, for example, a low quality tissue, in this case, to combine this, you will provide the results shorter. And another thing that I want to share with you, okay, here, can you give me a minute, please, just to change the presentation, because maybe we have to provide also, Dimitris, here as a key message is this. Give me a moment. I want this now. Because we are discussing about liquid biopsy. I found the presentation. I want to share with you 2 slides more only. Okay, I found the slide. Guys, I think that we have to add. I find
the blood, and then another 10 days, and then we receive the answer. So
I think that we have to add also.
And then we are going to provide with a combo at the same day.
Here, just a minute. Dimitris is discussing something. So he was speaking.
Okay.
Are you back?
No,
No, we're not muted. He will, because he didn't hear you. He was trying to tell something, and I told him that, we were discussing.
That test will speed up faster.
Okay, guys. Okay, from since May 2022-5 in England, and we know that NICE is very conservative. They are using this blood test first approach for cancer patients with lung cancer and breast cancer. A blood test which speeds up cancer diagnosis by 2 weeks and can help patients with suspected lung and breast cancer receive targeted treatment is now available across the NICE in England. The ctDNA test will be used before traditional tissue biopsies in a blood test first approach. and an independent health economic assessment of the pilot estimated the test could save the NIS about 11 million pounds per year in lung cancer care, and the NIS is now looking at its use in a range of other cancers, including pancreatic and gallbladder cancer. Because, guys, here the problem is to have in the initial diagnosis, to have as quick as possible the molecular profile. And surely this is important for lung cancer. For this reason, okay, I believe now in GeneCore with complete DX liquid, in the case that we don't have the adequate tissue or low quality tissue, in the case that we need to have a faster turnaround time, in the case that we need to enhance the positivity rate. For all these reasons, now it is not a very expensive test. We are discussing for a liquid, a combo test, CIVD test in 10 working days to have all this information. So in my opinion, and I believe that Complete DX combo lung is amazing tool. Okay, give me 1 minute to upload again.
Okay. So far, I think right now we are clear. We are even more clear because we already delivered our food. So everyone is concentrated on eating lunch, probably. So maybe we can make our break. We can have discussions here with me if any questions. And
so what
after that we can...
What time do you want to continue? In half an hour? In 45 minutes?
No. 20 minutes would be enough.